subject of today's lecture is diagnosis, treatment, and prophylaxis of myocardial infarction. You cannot rewrite, you can just listen. This lecture will be on the site. I'd like to present you this report. 75 years old man is admitted to the hospital with a 60-minute history of severe crushing chest pain, anxiety, diaphoresis, and dyspnea. The chest pain is intensive, pretesternal, and radiates up to the neck, shoulder, and jaw, and down to the ulnar aspect of the left arm. Anamnestic date. During the several months before, he marked recurrent retesternal pain, which are relieved by nitroglycerin. He had the following prodromal symptoms. In the days preceding the event, fatigue, chest discomfort, malaise. Physical examination. Patient describes his pain as squeezing and burning. His BP is 160/90 mmHg. Heart rate is 95 per minute, rhythmic. No murmur sound in heart auscultation. Respiratory rate is 22 per minute. No wheezing sound in lungs auscultation. No fever. What kind of syndromes are typical for him? How do you think? What kind of syndromes? What he said? Pain. Chest pain. Chest pain. What else? Angina pectoris. What else? His blood pressure. Yes, arterial hypertension. Hypertension. What else? We can return. Respiratory rate, respiratory distress, and diaphoresis, he said. Pain syndrome, asthenoneurotic syndrome, arterial hypertension, respiratory distress syndrome. Which syndrome is leading? Really? Pain. Pain. Why pain? Why pain? The squeezing, burning, the severe pain. Pain syndrome is leading because it was a reason for the patient hospitalization. Yes, chest pain. What do you suspect at this patient? Pulmonary embolism, pneumothorax, pneumonia or pleuritis, esophageal reflux, aortic dissection, myocarditis, pericarditis, angina pectoris, myocardial infarction. Why we have to take these illnesses? How do you think?
All of behind of the retroesternal.
Yes. Yes, because they can damage chest organs. Pulmonary embolism. Abrupt onset of the pain. Location is often lateral. Associated symptoms of dyspnea, tachycardia, and occasionally hemoptysis. This is syndromes and symptoms typical for our patient. Has this disease our patient?
No.
Why? Hemoptysis present on our patient? Yes or no? No. This symptom is absent of our patient. Pneumothorax. Sudden onset of pleuritic chest pain. Location lateral to side of pneumothorax. Dyspnea, decreased breath sound, tympanic percussion sound. Pneumothorax, do you know what is it?
Yes.
Yes. Abnormal gas in the pleural space. Yes. And therefore, tympanic percussion sound can be. Has tympanic percussion sound? No.
Small malnutrition.
Yes. pneumonia or pleuritis. Localized sharp, knife-like pain. Pain is aggravated by inspiration and coughing, dyspnea, fever, rales, occasionally pleural rub. Has these symptoms in our patient? No. Esophageal reflux disease, deep burning discomfort that may be exacerbated by alcohol, aspirin, or some foods, worsened by postprandial recumbency, relieved by antacids, pain connected with swallowing. Is it typical for our patient? No.
Because there is no any pain connected with the swallowing.
Yes. He didn't tell about the pain in swallowing. Yes? Aortic dissection, tearing, ripping pain with abrupt onset, associated with hypertension and or connective tissue disorder, depending on the location of dissection, loss of peripheral pulse, pericardial tamponade, murmur of aortic insufficiency. Aortic dissection, is it clear for you?
Yes.
This dissection of aorta you see here, yes, has these symptoms, patient. Murmur aortic insufficiency.
Yes.
Our patient has
Yes.
murmur.
No.
Murmur sound. No murmur sound. Has a loss of peripheral pulse. Has it? Here? No. Myocarditis. Mild symptoms of chest pain, fever, sweats, chills, and dyspnea usually present with signs and symptoms of acute decompensation of heart failure, for example, tachycardia, gallop, mitral regurgitation, edema. No fever, no gallop, no mitral regurgitation. Pericarditis. The duration of the pain is hours to days. Sharp, retrosternal pain that is aggravated by coughing, deep breath, or changes in body position, relieved by sitting and leaning forward.
Because also has some deep problems like
Can be. You think can be? Okay. Angina pectoris occurs at rest or with minimal exertion, usually lasts more than 10 minutes, is severe and new onset, and or occurs with a crescendo pattern, more severe, prolonged, or frequent than previously, usually relieved by nitroglycerin. Can be. Myocardial infarction. The duration of the pain often more than 30 minutes, often more severe than angina, and relieved by nitroglycerin, may be associated with evidence of heart failure or arrhythmia. Arrhythmia is absent of our patient, but can be. Three disease can be of our patient. How we can exclude that diseases? How we can exclude? What we have to do for exclusion? How? How? What we have to do? ECG. Yes. What kind of diagnosis we can put him? You mentioned. No, diagnosis. You consider myocardial infarction? What do you think, students? Myocardial infarction. Patient diagnosis can be myocardial infarction because the duration of the pain more than 30 minutes, more severe than angina. Myocardial infarction is the rapid development of myocardial necrosis by critical imbalance between oxygen supply and demand to the myocardium. Pathophysiology.
A heart attack happens when blood flow to part of the heart muscle is blocked. The blockage harms part of the heart muscle because it is no longer getting oxygen from the blood. Most heart attacks are caused by a blood clot that blocks one of the coronary arteries. Occasionally, a heart attack can be caused by a spasm or tightening of a coronary artery. Coronary arteries are the blood vessels that supply oxygen-rich blood to the heart muscle. In coronary artery disease, the inside of the coronary arteries narrow and harden because of the buildup of fatty material called plaque. Blood flow to the heart muscle is decreased. If the plaque cracks or breaks open, a blood clot can form on the surface of the plaque. The clot, also called a thrombus, can completely block blood flow in the artery. Once the flow of blood is blocked, a heart attack will happen when a part of the heart muscle becomes damaged. The heart may not be able to pump blood throughout the body very well. This can cause chest, arm, back, or jaw discomfort or pain, shortness of breath, or other symptoms. After a heart attack, if the blockage is not treated and removed within a few hours, the damaged heart muscle will begin to die and be replaced by scar tissue. This heart damage may not be obvious or may cause severe and long-lasting symptoms because the heart cannot pump blood well. Another less common cause of a heart attack is a severe spasm or tightening of a coronary artery that cuts off blood flow to the heart muscle. Spasms can occur in people with or without coronary artery disease. Just as clots may do, spasms can completely block blood flow in the artery. Once the flow of blood is blocked, a heart attack will happen when a part of the heart muscle becomes damaged. The heart may not be able to pump blood throughout the body very well. This can cause chest, arm, back, or jaw discomfort or pain, shortness of breath, or other symptoms. After a heart attack, if the blockage is not treated and removed within a few hours, the damaged heart muscle will begin to die and be replaced by scar tissue. This heart damage may not be obvious or may cause severe and long-lasting symptoms because the heart cannot pump blood well.
You saw the pathophysiology of myocardial infarction and heart attack. Classification. Acute coronary syndromes include ST elevation, non-ST elevation, unstable angina. Cardiac markers in circulation indicates myocardial infarction and help categorize MI and is a useful adjunct to the diagnosis. There are anatomic or morphologic classification. It is transmural when damaged full thickness, non-transmural partial thickness, and according to ACG classified Q-wave MI, non-Q-wave MI does distinguish transmural from a non-transmural MI as determined by pathology. Chest pain, anterior precordial tightness. Clinical picture. Chest pain, anterior precordial tightness. Pain may radiate to jaw, neck, and epigastrium. Dyspnea, angina equivalent full left ventricle function. Nausea, abdominal pain with inferior or posterior MI, and anxiety. Nausea with and without vomiting, diaphoresis or sweating, syncope or near syncope. Elderly present is with fatigue, syncope, or weakness. As many as half of MI are clinically silent. Physical examination. The physical exam can often be unremarkable. Can be hypertension, hypotension, acute valvular dysfunction may be present. Rails, maybe, neck vein distension can be. Third heart sound may be present. A fourth heart sound, saying about poor left ventricle compliance, dysrhythmias, low-grade fever. Most frequent cause is rupture of atherosclerotic lesion within coronary wall with subsequent spasm and thrombus formation, coronary artery vasospasm, ventricular hypertrophy, hypoxia, coronary artery emboli. Next causes: smoking, cocaine, coronary anomalies, aortic dissection, Kawasaki disease, Takayasu arteritis, increased afterload which increases myocardial demand. Risk factors for atherosclerosis: age, male, gender, smoking can be 2, hypercholesterolemia and triglyceridemia, diabetes mellitus, poorly controlled hypertension, type A personality, family history, sedentary lifestyle. Differentials: acute coronary syndrome, anxiety, aortic stenosis, asthma, cholecystitis and biliary colic, cholelithiasis, COPD. Aortic dissection, endocarditis, esophagitis, shock, myocarditis, pericarditis, pulmonary embolism. Mechanisms of myocardial damage: the severity of MI is dependent of 3 factors: the level of the occlusion in the coronary, the length of time of the occlusion, the presence of absence of collateral circulation. Pre-hospital care of our patient: nitroglycerin given sublingually 3 times. Pain was not relieved. And ECG. A normal ECG doesn't exclude acute coronary syndrome. High probability include ST segment elevation in 2 contiguous leads or presence of Q waves. Intermediate probability ST depression, T-wave inversions are less specific. Localization of MI: ST elevation only, inferior wall, second, third, AVL, lateral wall, first, AVL, V4, V6, anterior septal, V1, V3, anterior lateral, V1, V6, right ventricular, RV4, RV5, posterior R to S ratio more than 1 in V1 in T-wave inversion. Inferior wall, second, third, and AVL. As you see here, you can see ST elevation on second, third, and AVF. And reciprocal changes on AVL, V2, V3. Anterior septal apical, V1, V4. We can see how ST begins elevate on V1, elevated on V2, V3, V4, even V5. Posterior lateral myocardial infarction. We can see ST elevation on V5 and V6. Our patient's ECG. On ECG, we can see ST elevation in V2, V5, R wave amplitude decrease in V1, V2, and formation Q wave in V2 and V3. Is it seen for you? Can you distinguish everything? R wave amplitude decrease on V1, V2, and Q wave formation on V3. ST elevation on V1, V4 on ECG confirms the presence of myocardial infarction in our patient. Our patient's pre-hospital care: immediate administration of aspirin, 325 mg per dose, intravenous access, supplemental oxygen, pulse oximetry, isosorbate dinitrate infusion. Our patient's hospital management: troponin T and I, creatinine kinase, infarction, myoglobin, complete blood count, chemistry profile, lipid profile, C-reactive protein, and other information, markers, chest X-ray, echocardiography. Cardiac biomarkers. Cardiac biomarkers are protein molecules released into the bloodstream from damaged heart muscle. Since ECG can be inconclusive, biomarkers are frequently used to evaluate for myocardial injury. These biomarkers have a characteristic rise and fall pattern. On this graph, you can see how increased troponin on patient and days after onset of acute MI, how long can be present in blood, troponin, creatine phosphokinase and diffraction, and myoglobin. Troponin T and I. These isoforms are very specific for cardiac injury. Preferred markers for detecting myocardial cell injury. Rise 2 to 6 hours after injury, peak in 12-16 hours, stay elevated for 5-14 days. Creatine kinase. Creatine kinase is found in heart muscle NB fraction, skeletal muscle MM fraction, and brain BB fraction. Increased in over 90% of myocardial infarction. However, it can be increased in muscle trauma, physical exertion, post-operation, convulsions, and other conditions. I'd like to tell troponin T and I, two forms of troponin. T can be present in skeletal muscle too. I form present in heart muscle. Creatine kinase NB. Time sequence after myocardial infarction begins to rise 4 to 6 hours, peaks 24 hours, returns to normal in 2 days. NB2 released from heart muscle and converted to NB1. A level of NB2 more or equal 1, and a ratio of NB2 NB1 more than 1.5 indicates myocardial injury. Myoglobin. Damage to skeletal or cardiac muscle release myoglobin into circulation. Time sequence after infarction rises past 2 hours, peaks at 6 to 8 hours, returns to normal in 20 to 36 hours. Have false positive with skeletal muscle injury and renal failure. All patients' cardiac biomarkers. His cardiac biomarkers were positive: troponin T and I, creatine kinase, myoglobin. These data confirm myocardial infarction in our patient. Complete blood count indicates if anemia is suspected as precipitant. Leukocytosis may be observed within several hours after myocardial injury and returns to level within the reference range within 1 week. Chemistry profile. Potassium and magnesium levels should be monitored and corrected. Creatinine levels must be considered before using contrast for coronary angiography and percutaneous revascularization. C-reactive protein. C-reactive protein is a marker of acute inflammation. Patients without evidence of myocardial necrosis but with elevated C-reactive protein are at increased risk of an event. Chest X-ray. Chest radiography may provide clues to an alternative diagnosis, aortic dissection or pneumothorax. Chest radiography also reveals complications of myocardial infarction such as heart failure. You can see on this chest X-ray acute MI and pulmonary edema like butterfly distribution. Our patient's chest X-ray. As you see, no many changes on his chest X-ray. Echocardiography. Use two-dimensional and N-mode echocardiography when evaluating overall ventricular function and wall motion abnormalities. Echocardiography can also identify complications of MI, for example, valvular or pericardial effusion, ventricular septal defect. Our patient's echocardiography. This is a two-dimensional echocardiography and the 4-chamber position. You can see left ventricle, right artery, left artery, and the arrows show the affected walls. Our patient's clinical diagnosis: ischemic heart disease, transmural myocardial infarction of the anterior septal apical zone, acute period. And when you will write on your case history, you have to write like this. Therapy. The goals of therapy in acute MI are the expedient restoration of normal coronary flow and the maximum salvage of functional myocardium. Antiplatelet agents. Aspirin at least 160-325 mg immediately interferes with function of cyclooxygenase and inhibits the formation of thromboxane. Aspirin alone has one of the greatest impact on the reduction of MI mortality. Clopidogrel, ticlopidine have not been shown in any large-scale trial to be superior to aspirin in acute MI. Supplemental oxygen. Because MI impairs the circulatory function of the heart, oxygen extraction by the heart and other tissues may be diminished. Supplemental oxygen should be administered to patients with symptoms and or signs of pulmonary edema or pulse oximetry readings less than 90%. Nitrates. IV nitrates to all patients with MI and congestive heart failure, persistent ischemia, hypertension, or large anterior wall MI. Primary benefit vasodilator effect metabolized to nitric oxide in the vascular and endothelium, relaxes endothelium. Vasodilation reduces myocardial oxygen demand and preload and afterload. Beta blockers, recommended within 12 hours of MI symptoms and continued identifiably, reduces myocardial mortality by decreasing arrhythmogenic death, decreases the rate and force of myocardial contraction, and decreases overall oxygen demand. Unfractionated heparin forms of chemical complex with antithrombin 3 inactivates both free thrombin and factor Xa. Recommended in patients with MI who undergo percutaneous transmural coronary angioplasty or fibrinolytic therapy with altiplase. Low molecular weight heparin, direct activity against factor Xa and 2A, proven to be effective in treating acute coronary spasms that are characterized by unstable angina or non-ST elevation MI. Their fixed doses are easy to administer, and laboratory testing to measure their therapeutic effect is not necessary to make them attractive alternative of unfractionated heparin. Thrombolytics, indicated with MI and ST segment elevation greater than 0.1 millivolt in 2 contiguous ECG leads or new onset left bundle branch flow who present less than 12 hours but not more than 24 hours after symptom onset. The most critical variable achieving successful fibrinolysis is time from symptoms onset to drug administration. Thrombolytics, as a class, plasminogen activators have been shown to restore coronary blood flow in 50–80% of patients. Contraindications are active intracranial bleeding, cerebral vascular accident, 2 months, CNS neoplasm, hypertension, coagulopathy. Erythroblast slightly higher angiographic patency, but did not translate into survival benefit. Intracranial bleed risk major drawback. Glycoprotein 2B, 3A antagonists. Potent inhibitors of platelet aggregation used during percutaneous coronary intervention and in patients with high-risk features, acute coronary syndrome, have been shown to reduce the composite endpoints of death, reinfarction, and the need for target lesion. Percutaneous coronary intervention. Alternative is performed by a skilled operator in an experienced center. Standard is a door-to-balloon time of 90 minutes. PCI can successfully restore coronary blood flow in 90–95% of MI patients. PCI definitive survival advantage over fibrinolytics for MI patients who are in cardiogenic shock. Surgical revascularization, emergent or surgical revascularization in setting of failed PTCA in patients with hemodynamic instability in coronary anatomy amenable or to surgical grafting. Also indicated of mechanical complications of MI, including VCD, free wall rupture or acute mitral regurgitation, carries a higher risk of perioperative mortality than elective cuts. CABG, coronary artery bypass graft. Percutaneous coronary intervention. See here, here you can see thrombus and the contrast in arterial, not properly flow through this spasm and blocked part. Our patient's PCI, the same picture. Our patients in hospital treatment, unfractionated heparin, IV, bolus 60-70 unit per kilogram, maximum 5,000 unit, beta adrenergic blocker, IV, metoprolol 5 mg within 1 to 2 minutes with 5-minute intervals. Total dose is 15 mg. Emergency PCI with stent implantation within 90 minutes after the pain occurred. Stent implantation. You see here stent and narrowed part of vessel and how this stent.
This is balloon.
Yes. No, and the stent is here. Yes.
It is not possible in the stent any thrombus formation after injury.
Yes, we will discuss about now. Lipid management. All post-MI patients should be on step 2 diet, less than 7% of calories from saturated fats. Post-MI patients with low-density lipids, more than 100 mg per deciliter, are recommended to be on drug therapy to try to lower levels to less than 100 mg per deciliter. Recent data indicate that all MI patients should be on statin therapy regardless of lipid levels or diet. Long-term medications. Most oral medications instituted in the hospital at the time of MI are continued long-term. Aspirin, beta blockers, and statin are continued identifiably. EC inhibitors identifiably in patients with chronic heart failure, ejection fraction less than 40%, hypertension or diabetes. Following outpatient management for our patient. Antiplatelet therapy with ticagrelor during the 1 year, beta blockers, statins. Do you have questions? You asked about the thrombus formation. Antiplatelet therapy during the 1 year can prevent thrombus formation after stenting implantation. Do you have any other question?
No.
No?
About SP.
SP.
If any person have heart attack, then we should provide SP. But ma'am, SP also side effect in which person who in stomach or ulcers.
Yes. Good question.
Doses.
Good question. Yes. Have to be regulated doses at first, and the second, we have to give patient proton pump inhibitors.
Yes.